Hello, my name is Michael Sharpe. I'm an intensivist at London Health Sciences Centre, University Hospital in London, and critical care LHIN leader for the Southwest LHIN. Today I'd like to talk to you about the life or limb policy, and we will be answering some questions regarding this. The life or limb policy essentially has two functions. First is to identify those patients that have a life or limb diagnosis whereby their life and or limb is at risk if they do not receive appropriate care in an appropriate time. The second function is to facilitate the transfer of that patient from a referring physician to an institution that is closest to that patient and that is capable of caring for that patient's needs. This policy has been embraced by all stakeholders across our LHIN, and that has been very rewarding for everyone. We have developed a systematic approach of caring for acute care patients. This will lead to reduced time for a referring physician to talk to an intensive care physician, and thereby will facilitate immediate, appropriate care of that particular patient. It will decrease frustrations that we've previously shown and experienced in the past, whereby ICUs are always filled and the referring physician has made multiple phone calls to multiple institutions trying to get care for his patient. This will eliminate all that frustration. This will eliminate all that time that is wasted attempting to not only talk to a physician for referral and consultation, but also to deliver that patient to an institution that can care for that patient in an appropriate time. During the development of this policy, we talked to the critical care units of our level 3 hospitals in our Southwest LHIN. With their input, we developed a list of diagnoses that we consider to be life or limb and involves all surgical and medical disciplines. As a result of that, we are now more aware of patients who present with particular diagnoses whereby their life and or their limb are being compromised. This also makes us aware of we need to deal with this situation acutely. By definition, we propose that any patient who has a life or limb diagnosis be transferred to a receiving institution within 4 hours. All stakeholders have supported this and have agreed to that, including the receiving intensive care unit physicians and also the administrators of the hospitals, whereby resources will be affected. The no refusal aspect of this policy is the most important part of this policy. The intent is to treat this patient in the most expeditious manner possible. If we have an ICU that has 100% occupancy, the inclination previously was to transfer this referral to another institution. We've asked hospitals across our Southwest LHIN to determine what diagnoses they are capable of taking care of. However, there are circumstances whereby they do not have all resources available to them 24 hours a day, 7 days a week. For instance, some hospitals have support from a general surgeon, for instance, but may not have that support 7 days a week. And therefore, if there is a situation whereby a patient is referred to them that has a general surgical problem, obviously they will not be able to take care of that patient. The process then will go back to critical, and the next closest hospital capable of taking care of this particular surgical problem will be notified, and the process carry on from that point on. So we understand that under various circumstances, resources that currently exist in hospitals today may not be available tomorrow or the day after, and therefore they may not be able to take care of that particular problem at that instant. We recognize that. But the intent is, if resources are available, you are capable of taking care of that problem, this patient will not be refused, and the care will be provided to that patient in a very timely manner. We are also very aware that this will result in appropriate care for our most sick patients in our Southwest LHIN, and that's basically what this is all about. Therefore, we have an obligation as physicians who work in level 3 intensive care units to take care of these patients, whereby these patients are currently sitting in a hospital that is unable or incapable of caring for the problem, and therefore we need to take these patients immediately and care for their illness. This is good patient care. This will save lives, and this will have a significant improvement in patient morbidity as well.